Hello, everyone. This is Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Thank you, everyone, for attending our discussion today, Regenerative Medicine treatments for knee pain and arthritis. If some folks could please indicate on the chat whether you can hear me clearly. Let me know if the audio is okay and if you can see the screen clearly as well. Okay, great. Thank you. So what will you get from this webinar today? So you'll learn about the best available non-surgical regenerative medicine treatments for your knee issues, including for arthritis, tendinitis, and injuries. What is legitimate and not legitimate in the field of regenerative medicine, and the 9 things your physician must know if they are an expert in regenerative medicine. Great. Okay, yeah, I thank you for the feedback from everyone. I think my video is not working very well right now, but hopefully you can see all of the slides. If you can, I'll keep on going at this point. Yeah, and as I'm talking, please enter any questions or thoughts that you want to discuss. You can put that into the chat, and as I am discussing, I will every so often start to answer some of those questions. Great. So the big question is, what would you do if your knee pain was controlled? How would your life improve? What exercise would you restart or continue? And what activities with family and friends would you participate in? So who am I? My name is Siddharth Dambar, physician at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, as well as specialist in image-guided musculoskeletal injections. I've been in practice since 2008, been working in regenerative medicine since 2008 as well. And I've been in the Regenix Network, which is the largest collection of physicians specializing in regenerative medicine since 2012. Essentially, I got involved in regenerative medicine because I started to notice, not only amongst my own patients, but even amongst family, friends, and myself, that the typical solution for musculoskeletal issues, whether it's arthritis or tendinitis, was really not up to standard, in my opinion, from a medical standpoint. And really, the problems with traditional care include the following. Traditional care is generally pain medication, ice, and rest. It can mask the pain, but there's really no attempt to fix the problem. And you are, for all purposes, you're essentially waiting for eventual surgery. It's a really terrible model of care. The example that I give is, if you had early high blood pressure, you wouldn't wait until you had your first heart attack or stroke to treat that. You would actually try to treat the high blood pressure, either with diet and exercise or eventually medication, so that you could prevent from developing those other issues. For some reason in musculoskeletal medicine, that's just not the traditional approach. Other problems with traditional care, the typical pain medications that are used, NSAIDs or anti-inflammatory medications, they have a lot of side effects, including kidney, stomach, liver, heart, and bleeding issues. Chronic opioid use, as we all know in this country now, is devastating to individuals and communities. It's just not a good solution for people. The traditional injections that are used, whether those are steroid injections or nerve blocks, have issues. Steroid injections can damage tissue. They have infection risks. They can also, if you give them too often, increase your risk of metabolic syndrome, diabetes, and even osteoporosis. Nerve blocks and radiofrequency ablation that are frequently used, and actually more and more even for knee pains. The problem is that they can damage the nerve, which can then lead to muscle weakness as well. And realistically, there's a reason why you have those nerve fibers there. In large part, they offer not only control of the muscle, but they can also offer proprioception, which means that your joint recognizes where it is in space. And as you lose that, you can actually have problems with function as well. And so the nerve blocks and radiofrequency ablation that you see for knee issues is just not a good option either. Surgery. What's the problem with surgery? Well, a few things. Number one is, there's a higher risk: bleeding, infection, tissue damage, anesthesia risks, and even heart disease issues. Many routine surgeries, more importantly, or equally as important, are proven not to be as effective as they originally were thought to be. For example, knee arthroscopy. If you already have arthritis, the problem with knee arthroscopy is that it can accelerate arthritis because it creates more instability. And in fact, it is not recommended if you already have any degree of arthritis. That is not only my opinion, that is literally the medical literature over the last 15 years. And there are countries, including Canada and England, where if you already have arthritis, knee arthroscopy is not even allowed. It will not be covered by insurance. And most of the younger orthopedic surgeons that are coming into practice now have that understanding and recognize that. But it's still one of the most common surgeries done on people. Surgical repair, if you have an ACL or MCL tear, can be helpful, of course, but it does not prevent progression to knee arthritis because there is continued instability in the knee. Knee meniscus surgeries, as they're frequently reported as repairing the meniscus, but the reality is the vast majority of those surgeries are actually removing meniscus tissue. The problem with that is you leave the knee joint more unstable. And while there may be cases where you can indicate that meniscus surgery is appropriate and would be helpful, the majority of knee meniscus surgeries that are being done are likely not needed and are actually leaving knees more unstable, causing more progressive arthritis. And so we're looking for better options, and regenerative medicine can really fill in that gap. So searching for better options in terms of avoiding a lot of the side effects of these traditional care and low risk at the same time. Can we actually treat the cause of the problem, and can we give longer term improvement? And that's where regenerative medicine comes into play. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the field of medicine where you use your own body's cells to treat musculoskeletal conditions: arthritis, tendinitis, injuries, and back pain. The normal healing process essentially is the following. If you have, let's say, a small cut in your finger, it's a small injury, and your body responds by infiltrating cells, growth factors to enter that area. That inflammation leads to stimulation of your local mesenchymal stem cells. You then have a slow, progressive remodeling process and then cellular repair process of that injury. So tissues with poor blood flow do not heal well. That includes tendon, cartilage, ligaments, discs, labrum, and meniscus. So regenerative medicine is essentially the process of isolating those cells that we know are useful in the normal healing process and injecting those cells under high-level ultrasound or X-ray guidance to coordinate that normal healing process in that tissue that's been damaged. So why regenerative medicine? Well, for starters, it treats the source of the problem, meaning arthritis, injuries, tendinitis, ligament injuries. They're not just structural issues, they're actually biologic issues. The tissue's damaged and the tissue's not repairing well on its own. At a biologic level, you can help to treat that. This is certainly safer than surgery. We're talking about a small needle stick as opposed to a larger arthroscopic tunnel or open surgery where you're really opening up tissue. You're not removing tissue. You're not adding any hardware either. You're using your own existing hardware. This is effective for most musculoskeletal conditions. And in fact, for those of us that are really pretty deep into regenerative medicine, we strongly feel that 80% of traditional orthopedic surgery will eventually be managed by regenerative medicine, in the same way that the vast majority of what used to be handled for cardiac disease with open heart surgery is now handled via needle-based procedures by cardiologists. So how does regenerative medicine work? Essentially in the following ways. It helps to optimize damaged cellular health of tissue. So again, if you have those damaged tendon, joint, ligament, nerve cells, essentially when we re-inject your own stem cells or platelets, the growth factors from that help to get those damaged cells to start functioning better. So damaged cells, they don't produce the right kind of proteins and enzymes that you see in a healthy cell. And by adding your own cells into that area, you're basically getting those cells to start functioning in a more correct fashion. You're on a cellular level, biologic level, you're getting those cells to start functioning like a normal joint. In addition, when you have tissue that's been chronically damaged, the mesenchymal stem cells can get overwhelmed, damaged, worn out, and by injecting your own stem cells into that area, you're essentially now putting a bolus of fresh, healthy stem cells back into an area where those cells have been damaged. So helping to recover from chronic injuries, it's helpful to have a better, healthy supply of those cells. In addition, we're able to help improve stability. Stability is a big one in terms of regenerative medicine. When you strengthen the supportive structures, including whether you're talking about ligaments, tendons, other soft tissue structures around the joint, you can actually help with pain and function longer term. I'll talk more about stability in a little bit, but that is a really key aspect of regenerative medicine. You can help reduce chronic inflammation. In a chronically arthritic joint or tendon that's been damaged, what you find are a lot of chronic inflammatory chemicals, and we can actually help to reduce that chronic inflammation significantly long term. And we can also help to improve neuromuscular health. The body is a very fine, complex instrument where you have an interplay of nerves, muscles, tendons, ligaments, joints, and there's a lot of feedback that goes back and forth. We can help to improve that neuromuscular health by treating the right kind of muscle and nerve tissue at the same time as well. So before I move on, someone had asked, if you've had some of these other treatments, can you still benefit from the regenerative medicine treatments? And the answer is yes, for the most part. If you've got a replaced joint, I wouldn't necessarily recommend injecting cells into the joint itself. On the other hand, if you've had, let's say, arthroscopic surgery, steroid injections in the past, that is very common, and we see that all the time with patients. That's pretty routine, and that can certainly still help. Somebody asked about why do we inject into the bone? Great question. So this is a very interesting question. So when you look at MRIs, let's say of the knee for knee arthritis, you can frequently find a lot of abnormalities, and very few of them will actually correlate with pain and function. One of them that does is if you have inflammation or swelling in the bone, the subchondral bone, that correlates very well with pain. So treating the bone helps if you have moderate to more advanced arthritis of the knee, because number one, that correlates with pain. Number two, the cartilage itself does not have a very good blood supply on its own, but what it does receive is blood supply from the bone, the subchondral bone. And if that bone is swollen or damaged, then it'll actually lead to more progressive damage in the cartilage as well. The other aspect to that is there's now progressively more and more data around the world showing that if somebody has moderate to advanced arthritis of the knee or the hip, that instead of only treating the joint, if you treat the bone as well, you'll get a better long-term response and improvement in pain as well. Anecdotally, the great example I like to give my own mother-in-law, I've treated one or other of her knees over the last several years. I've treated her own knees without treating the bone, only treating the joint. And then a couple of years later, treated the joint and the bone. And there's a big difference in terms of not only improvement in pain longer term, but also durability of treatment as well when you treat the bone as well. So it's another pain generator, and it's a very important one, possibly the most important one, which is why we're treating that more often as well. Good question. So some regenerative medicine basics. Is this legal? And the answer is very clearly yes. There are some very strict guidelines from the FDA. And if you're using your own cells, and if you're using cells that are not significantly altered or adjusted, and if you're injecting them into damaged orthopedic tissue, that is legally compliant and appropriate. Next question, if I'm older, shouldn't I use someone else's cells? And the answer is no. For the vast majority of orthopedic conditions, the evidence out there, this is not only from within the Regenetics Network, this is now evidence from around the world, is that using your own cells is not only adequate, but it's safe and appropriate. There are additional risks to using someone else's cells, namely infection risk, transmission of other kinds of illnesses as well if you're using someone else's cells. The other aspect to this is that it is frankly illegal to inject someone else's live stem cells into somebody else. The only exception would be for certain childhood leukemias. I'll talk a little bit later about some of the amniotic and umbilical cord treatment options and what are some of the issues there. Is there an age limit for treatment? And the answer is no. When you're looking at knees and other joints, the one exception would be hips, that these other joints, knees, lower back, shoulders, elbows, ankles, and neck are not impacted by age in terms of improvement. Your body is fine-tuned to using its own cells for normal repair process, which is why you can take someone who has who's older and may have a chronic issue and they can still respond very well to treatment. I will actually discuss some more examples later on. That's a good question. Repeat treatment every year. No, that is not required every year. What I recommend for people that have chronic issues, if you have an acute injury, you may only need one treatment realistically, just because you're catching somebody at an early stage. If you have a more chronic issue, let's say 10 plus years of arthritis, my recommendation to people is after treatment one, you may need to get a repeat treatment a couple of years later, a few years later. We have data that shows that people can get a long-term durable response, but I still recommend to people that you may need a repeat treatment a few years later if your symptoms start to return or you're starting to develop any other kind of functional limitations. But I'll actually talk about that a bit more later on as well. So what kind of doctor does these kind of treatments? Number one, there should be a doctor who's focused on musculoskeletal conditions. If your physician is doing let's say as a plastic surgeon, they don't have the right kind of training for treating musculoskeletal conditions. I really think you should be focused on non-surgical treatments. This is different than orthopedic surgery. Orthopedic surgery is primarily cutting out tissue, occasionally repairing tissue, but it's mainly cutting out tissue. It's a different approach than how we deal with this on a regenerative medicine aspect. In addition, you really need to have very finely tuned skills when it comes to ultrasound and X-ray guidance when it comes to injecting. You're not just injecting into the joint, you need to inject at very fine detail levels, and that does require additional training when it comes to ultrasound and X-ray guidance. I'll talk a little bit later about what makes a proper regenerative medicine expert as well. So can these treatments help if you've already had surgery? Simple answer is yes. If you've had arthroscopic surgery, if you've had other injections, these treatments can certainly help. Again, if the joint's already been replaced, I would not recommend injecting cells into that joint at that time. General rules that I recommend to patients for orthopedic surgery is, as much as possible, try to keep your own anatomy, avoid surgeries that cut out tissue if possible. Always consider regenerative medicine treatment option if you've been recommended surgery as well. So some very key regenerative medicine concepts that I think it's helpful for you all to be aware of, and it'll help you when it comes to talking with your own physicians. Stability is an incredibly key concept when it comes to the musculoskeletal system. There's a concept of biotensegrity, which basically means if you take a structure and if you take the individual components of that structure and you put them in close approximation and tension, they will have more strength and stability than if you look at each one of those structures individually. That's key because this concept of prolotherapy in regenerative medicine, it's where you inject cells into the soft tissue supportive structures around the joint or tendon that's been injured. And by doing that, you'll create an additional level of strength to that tissue, which will then give you more pain relief and functional improvement compared to if you're only injecting into that individual unit structure. So the key here is layers and depth of treatment. So as an example, if you have, let's say, knee arthritis, it's not good enough to only inject into the joint. You need to be injecting the soft tissue structures, the ligaments, sometimes the tendons, the meniscus. If you don't, you're not going to get as good of a result. Most physicians who are doing this are not taking that approach, and that's a problem. It's an old school prolotherapy approach, but it makes a lot of sense and it makes a big difference in terms of outcomes as well. In addition, understand that that is a slow progressive strengthening process. And so it's not something you should expect an improvement within a week or two. It's something that really takes several months to really get maximum benefit. But doing it this way gives you a longer lasting result long-term as well. Knee stability is key. That picture on the right shows the ACL, PCL, lateral collateral ligament, and a medial collateral ligament. Improving stability leads to improvement in pain and function. And again, treating all those layers involved in pathology is key. The example that I gave, if you have, let's say, patellofemoral joint arthritis, that's arthritis underneath the kneecap, then you want to treat not only the joint, you may need to treat the bone as well, but you want to treat all the ligaments around that joint as well. It'll give you a more supportive joint and structure and better pain relief long term. On the other hand, if you have something like a meniscus tear without arthritis, you want to inject not only the meniscus, but you do want to inject the adjacent ligaments. Let's say you have a medial meniscus tear, you want to make sure you inject the coronary ligaments as well as the medial collateral ligament and any other ligaments that may be loose or injured on exam or imaging as well. It'll go a long way to giving a more supportive joint. So can tendon and ligament tears be treated? This is a great case study of a patient of mine who had a ACL tear. I'll show what that MRI looked like. In general, if you have a partial thickness tear, that can certainly be treated, absolutely. If you have a full thickness tear, some of those can still be treated. If the tendon or the ligaments are still closely approximated, that can still be treated. If they're fully retracted and pulled apart significantly, then that generally requires surgery. I can tell you that some of the more, open-minded orthopedic surgeons, and certainly the ones who deal with a higher level professional athletes, that when they're doing things like ACL tear repairs, they will add a person's own bone marrow concentrated stem cells as well, because they feel like they get a better longer term result as well. So it's a nice way to augment that kind of surgical treatment as well. So this is an example of a 28-year-old man who had an ACL tear playing recreational volleyball. I had treated him basically 2 months after treatment with his own bone marrow derived stem cells. At that 3-month mark post-treatment, he had no pain and he's restarted dynamic exercise. And I'll actually show you what that looks like. That picture on the right, to give you a sense for what we're looking at here. So this is the kneecap here. That's the femur. This is the tibia. This is the needle right here that's coming in. And essentially that is within the ACL, and the ACL is lit up. We put a little bit of contrast in there, and we're then injecting directly into that to treat that ACL tear. That takes really a very high level of X-ray guidance and experience. But if you do this correctly, you can take a ACL tear and you can actually significantly improve that tear. And in this case, to give you a sense of what that looked like, so this is his ACL tear. It's a very disorganized looking ligament. Normally this should be kind of a straight linear looking ligament. This is very hazy looking. This is described as either a high complex partial tear or a full thickness tear. This is essentially 3 months after treatment. And now you have a ligament that has a very straight line, linear looking presentation, small amount of fluid still there just from his treatment, but really a great imaging result. So clinically he had a great result in terms of pain relief and functional improvement and getting back to exercise. And from a imaging result, really a great look as well. There's another case study of an individual of mine who's got knee arthritis, 67-year-old woman. I'll show some more pictures later on, with chronic knee pain and arthritis. She had medial joint osteoarthritis, meaning on the inner part of her knee. She had been treated with her own bone marrow derived stem cells and PRP treatment for her medial joint, ligaments, and bone. And 5 years out, she's roughly 90% still pain relief. She's doing very well. OrthoBiologics. So OrthoBiologics are the biologic cells and tissues injected into damaged orthopedic tissue. And this uses a normal healing cascade. It's important to understand that you can use your own cells or someone else's cells. Legally compliant to use your own cells in this country. It is illegal to utilize somebody else's live cells. And I'll talk about that a little bit more in a moment. And again, keep in mind that when it comes to the literature, the medical literature, while there is considerable evidence of the effectiveness of bone marrow and platelets in orthopedic use utilizing your own cells, there's very little evidence of utilizing somebody else's cells. So this is an example of the first orthobiologic I want to discuss is platelets. Platelet-rich plasma is really one of the most commonly used orthobiologic treatments in this country currently. After an injury, platelets recruit other cells and growth factors to assist in repair. Utilizing focused inflammation helps to repair tissue damage. Platelet-derived growth factors also stimulate your own local mesenchymal stem cells, which is very helpful. So there's generally two different types of platelet-rich plasma that we use. There's platelet-rich plasma and platelet lysate. Platelet-rich plasma is where we take out several ounces of your own blood, concentrate that into a high concentration of platelets, and then inject that into the joint, ligament, tendons area that's been injured. Platelet lysate is where we take that same platelet-rich plasma and filter that and just take the growth factors from that and inject that. That is a better option for nerves and sometimes ligaments as well. You do this by doing a blood draw first thing, centrifuging this multiple times, and then concentrating it into the sort of concentrate that you want. Important to understand that you need to have flexibility in how you do this as a physician. Most physicians use generally a one-size-fits-all presentation to this. They don't take that kind of consideration. But if you have a joint issue, you should use, let's say, 14 to 20 times concentration of platelet-rich plasma. If you have a tendon issue, 7 to 10 times concentration of platelet-rich plasma. Most physicians that are using this use a one-size-fits-all system where they're getting anywhere from 3 to 5 times normal concentration of plasma, which is insufficient to get an optimal result. The other aspect to this, when you look on the screen, you'll see some blood tubes there. On the left side, you'll see platelet-rich plasma that is yellow colored. That means you've taken out the red blood cells. That's less inflammatory. On the right side, you've got platelet-rich plasma where you've got the red blood cells. That's more inflammatory. That can be helpful in certain muscle-related issues, but the vast majority of times you want to use platelet-rich plasma that doesn't have all those red blood cells. If you're getting platelet-rich plasma and you're getting something that's not fit with that, you need to be careful. You may not be getting a optimal treatment. This is a case study of a gentleman that has knee tendinitis. He's a cyclist. He originally presented with left knee pain. He was referred to me by a sports medicine physician because he had persistent pain despite physical therapy. His MRI and ultrasound showed that he's got patellar tendinitis. The image on the right is of an ultrasound and patellar tendinitis. This is the kneecap right there. You can see that, the X. This is the patellar tendon here. Over here, you've got your tendinitis and bone spurs as well. So the way that we treated him under ultrasound guidance, injected his tendon 2 times. On that screen or on that picture on the right, that long white structure coming in from the right side is the needle injecting into the patellar tendon. He had 2 treatments over 3 months. He was able to get back to full capacity in terms of cycling. 3 years later, he presented with his other leg now, his right knee hamstring strain. And again, treated with platelet-rich plasma and again, had a great response and is back to his normal activity. So the next big orthobiologic to be aware of are stem cells. These are the main cell that drives tissue repair and recovery after an injury. You can get these cells from yourself or from someone else. Again, in the United States, bone marrow-derived stem cells from yourself are legal. Some things that are not legal. Using someone else's live stem cells is not legal in the United States due to concern about safety issues. On the other hand, fat stem cells. Fat stem cells have been used frequently in this country. However, they are considered illegal at this time by the FDA, namely because of an enzyme that's utilized to isolate those cells called collagenase. The FDA has concerns that that may not be safe to use in humans. You can use fat and adipose for structural support, but it's not, strictly speaking, a stem cell treatment at that point. So I do frequently use it for tendon and ligament related issues because I do feel that it offers some benefit from a structural and connective tissue standpoint. But when it comes to stem cells, what's legal and compliant and with live cells in this country are your own bone marrow-derived stem cells. And that is where the vast majority of the literature of the effectiveness of bone marrow comes from, or from stem cells comes from. Some other things you may have heard of, amniotic and umbilical cord cells. Very important to understand that there are no live cells in these products. Why is that? So in order to be sold essentially over the counter to physicians, what's required is that after the tissue is received post-birth, they are then gamma irradiated, freeze-dried, and created into a powdered form, put into a glass vial, and then shipped to the physician's office. There, they can then sit on the shelf for 18 to 24 months. When they need to be used, you then re-inject some saline or water into that, and then rehydrate that. There's no live cells that are still remaining in that. 3 different organizations have looked at that. There's no live cells that are remaining. What you do have are growth factors. We'll on occasion utilize that for some tendon or muscle-related injuries, but as a standalone treatment, there are no live stem cells. And so if you're hearing that there's any live stem cells in there, that is inaccurate. IV stem cells, you may have heard about this as well. Again, no proven benefit for orthopedic conditions. If you're looking for benefit for cardiac or pulmonary conditions, I'm not the right person to talk about that. But from an orthopedic standpoint, there's no proven benefit that IV stem cells can be beneficial. You should also keep in mind that they can be potentially harmful if you're injecting something like bone marrow aspirate concentrate, which has a more thicker quality, and you need to be careful about injecting that into blood vessels. So stem cell treatment outcomes. So when we're talking about more advanced cases, you can still improve pain and function. And the reason why is because you can improve stability, you can improve inflammation, you can take damaged cells that are no longer functioning well and get them functioning at a normal level. You're improving this at a biologic level. It's important to understand that arthritis, even when it's advanced, is a biologic problem. Secondarily, it's a structural issue. It's really common for people to hear that they have bone-on-bone arthritis. And the problem with that is that that does not correlate with the level of pain. It's a really interesting study that came out of Korea recently. They found that when they looked at 20,000 people in their sort of national health system that had advanced arthritis, up to 30% of them did not have any pain, despite the fact that their x-rays showed that they had bone-on-bone arthritis. So arthritis is not a structural issue. It is definitely primarily a biologic issue. Can you improve X-ray and MRI images? In early stage conditions, that's possible. In advanced arthritis, unlikely. If you have a tendon tear that's limited, you can help with that. Ligament tears, you can help with that. Bone swelling in an arthritic joint, you can help with that. And if you have something called avascular necrosis, you can improve that imaging as well. But in terms of improving how the cartilage or the bone or the cartilage looks or an X-ray looks, that's less likely if you have advanced arthritis. But you can still improve pain. So this is a case study of an individual who has significant arthritis of his medial joint. And this is an example of how we're treating this under really high-level X-ray and ultrasound guidance. And in his case, he had significant medial joint arthritis and pain. And I injected his own bone marrow-derived stem cells into the medial joint, medial collateral ligament, and into the bone as well. So just to show you what that looks like. So down here, the top left corner, this is injecting into the medial joint. We're confirming it's in the right spot because you can see some contrast uptake in the medial joint. This is injecting into the bone. This is the medial femoral condyle. It's injecting into the bone, into the medial tibial condyle. That's another view of that as well. He's had a good reduction of pain so far, and he was treated roughly 7 months ago. He's currently down from a 7 out of 10 pain to a 2 out of 10 pain, and with increased activity. So he's on his way to a good result. Okay, before I get to that, good question. Someone is asking about, can you treat a meniscus tear? And the answer is yes. First and foremost, you have to always ask, do you have arthritis, a degenerative condition, and they happen to find that the meniscus is also degenerated, in which case you would really want to treat that as a degenerative condition, meaning treating all the ligaments and other soft tissue structures. On the other hand, if what you have is an acute meniscus tear, this is still a very good treatment option, in large part because under X-ray guidance and ultrasound guidance, you can hit the exact tissue that's actually been torn and injured. The key thing, though, is you don't want to only inject into the joint or into the meniscus. You need to still treat those other supportive structures that are around it. The classic thing that you see in a medial meniscus tear, for example, is that the medial collateral ligament on ultrasound will have some changes as well that have indicated that it's been injured, and you need to treat that as well. So another good question was, can you treat a joint that's bow-legged? You can treat the pain and some of the instability symptoms. You're not necessarily going to get rid of the bow-leggedness. You're not going to get rid of that varus abnormality. And the reason why is because if it's developed that chronically, it's not going to get back into place. What you will get, however, is pain relief and functional improvement, which frankly should be your goal. Knowing that x-rays do not correlate that well with pain relief or pain in general, the goal should always be pain relief and functional improvement rather than x-ray improvement, which, frankly is not even correlate with pain. So can we treat bone-on-bone arthritis? And the answer is yes. The treatment of advanced knee arthritis, on average, you can still get a 70% improvement in pain. Again, emphasizing arthritis is a biologic condition that's treatable with orthobiologic treatments. And in particular, if your range of motion is still intact and function is still generally intact, good outcomes are still possible. Caveats, I know we're talking about knees today. Caveats are advanced hip arthritis can be a challenge. Knees are different. Knees are made to handle a lot of damage and pain. So the classic thing that I hear from patients is that they've been told from another physician that they have bone-on-bone arthritis. And yet, when you examine them, you can push their knee through almost a full range of motion or a full range of motion. If you truly have bone-on-bone arthritis, you shouldn't be able to move through a full range of motion. And so knees they're built differently. And sometimes what can look like bone-on-bone arthritis does not correlate clinically. Sometimes what's called bone-on-bone arthritis on x-ray is not accurate because the patient's x-ray was not taken appropriately. It's not taken in a standing fashion. It's been taken while they're lying down. But the key thing to understand is that knees, even when they're advanced, can still get a very good result. Image guidance. Image guidance is a huge, huge part of what makes a regenerative medicine expert. You need to be able to do this as a physician under very high level x-ray and ultrasound guidance. The classic thing that I hear from some of my colleagues who don't use image guidance is that they have enough experience in order to do this without needing an ultrasound or x-ray. And my response to that is always, well, this is injecting, where I'm circling right now, into a patellar tendon exactly where the max tendinitis is. Like, you're just guessing if you can't do that with ultrasound. This is injecting into the medial joint. Well, you can do that blindly. Are you sure you're in the right joint? Are you sure it's not just hitting the ligament? Well, you can really confirm that with ultrasound, with x-ray and ultrasound guidance. Here, this is injecting into a ACL. You can only do that under x-ray guidance to this high level. You can't even really reliably do this under arthroscopy. And the reason why is because under arthroscopy, they have to inflate the knee with water, which then washes out any of the cells from there as well. And then lastly, again, injecting into the bone. You definitely would not do that blindly. That would be just downright dangerous. And so x-ray, ultrasound, high-level guidance is a requirement. And frankly, if your physician is not using that for your injection, I would recommend going elsewhere for sure. So how do you know if your physician is a regenerative medicine specialist? Here are the 9 things that I would recommend keeping in mind. This is what I consider when I want to know if someone's a proper regen med specialist. Number 1, they have to focus on orthopedic musculoskeletal issues only. If they're putting in some Botox in somebody's face on one hand and then running in to inject somebody's knee, that's not who you want to be seeing for this. That's not the right way to do this. The people you want to be seeing for this are people who are so focused on only this one thing. They are in the weeds for every single little detail. That's what creates professional growth, and that's what's going to give you a better outcome. Number 2 is they should really be focused on non-surgical treatments. Again, if they're offering you surgery on the one hand, but maybe you could do this on the other hand, they're not necessarily offering you the best way to do this. A regenerative medicine approach is different than a surgical approach. It's a very different approach to treatment that, in my experience, most orthopedic surgeons don't really have. Number 3, they should offer you only safe and effective treatments. I frequently find that a lot of pain docs will offer steroid injections, pain medications, or burning nerve tissue because it's covered by insurance. And they'll offer some of the regenerative medicine treatments on the side as well, here's another option. That's not right way to do it. As a professional, you should be offering what is your best option, what's your best shot. It shouldn't be you shouldn't be offering some of these other treatments that are not healthy for the tissue. Number 4, they should be able to offer you a candidacy rating. They should know what makes somebody a good, fair, or poor candidate. If they can't do that, then they don't understand this well enough. Number 2, if they tell you you've got advanced arthritis of the knee, you're not a good candidate, they don't understand the literature, because the literature shows that even if you have advanced arthritis of the knee, you can still get excellent results. Number 5, they should be collecting and publishing data. One of the great advantages of being in the Regenetics Network is that we're constantly collecting data, looking at outcomes and improving how we're doing things, whether it's how we're prepping cells, our injection technique, overall procedure technique. It's constantly being revised and improved based on data and what we're seeing. Number 6, image guidance for all treatments. As I showed before, most of these kind of treatments you cannot do blindly. And if your physician is doing these blindly, understand that they're not hitting the tissue like they should be. There's so many structures that you should be injecting regenerative medicine treatment, and doing it without guidance is derelict in my opinion. Number 7, understand how to treat instability. This is key because you can find physicians who have, especially pain doctors, who have very good image-guided skills when it comes to injection, but they don't understand the instability component. And so what I'll hear from patients is that they were treated by somebody else, and let's say their knee arthritis, and they injected into the knee joint, and that was it, and they only got a partial benefit. And what you realized was they didn't understand that in order to get better stability or better improvement, they should have treated all the other ligaments and soft tissue structures as well. If your physician for your issue is only treating that one spot and they're not treating the whole structure and those other supportive structures, they're likely not as experienced or knowledgeable about regenerative medicine. Number 8 is they should know the exact concentration of platelets and stem cell count that they are injecting. Most physicians are not measuring this. Most physicians use a one-size-fits-all system. You should have the flexibility to alter what concentration of platelets you're utilizing before injecting them so that you get the right kind of outcome. As I mentioned before, a high concentration of platelets is great for joints. Moderate concentration is great for tendons. And they should have that kind of flexibility. Most physicians don't. And they should be counting the amount of stem cells that you have as well when they draw out your bone marrow. If they're not, again, they're not really doing this at the highest professional level. And number 9, they need to understand the different orthobiologic products. If they don't realize that amniotic and umbilical cord cells do not have live stem cells, they're not an expert in this field. If they're telling you you should use somebody else's cells because you're older, they don't understand what the data shows, and they also don't understand what's in the products that they're injecting as well. And that's dangerous. You deserve a better approach and a better treatment. So regenerative medicine treatments offer safe and effective solutions for your pain. Great. Some other questions coming through, I see. How do we determine candidacy rating? Part of it depends on what the issue is, obviously, right? It's different to compare someone that has, let's say, an ACL tear versus someone that has chronic arthritis. For, let's say, someone who has a acute injury, let's say a tendon, meniscus, ligament injury, a lot of it depends on what's the severity of the injury, which you can take a look at under ultrasound and MRI. A lot of it depends on how is your range of motion currently, how unstable are things as well. When it comes to chronic knee arthritis, a lot of it depends on how, not so much what degree of arthritis they have, but more what's their range of motion like, what are the medical issues that they have, how's their instability on exam as well. And so someone can have an advanced degree of arthritis and still be considered a good candidate for treatment if they still have good range of motion, still reasonably physically active, and they're otherwise healthy. I saw a patient today who had relatively mild arthritis in the knee, which you would think would normally make him a good candidate for treatment. But because his diabetes was not ideally controlled, I told him you're probably more of a fair candidate because you need to get that under control before you want to be really considered a good candidate. So some of those other metabolic factors do make a difference, and you should try to optimize them if possible. Great question. So for knee arthritis, how do you determine if plasma or platelet-rich plasma treatment is needed or cell therapy is needed. So in general, platelet-rich plasma is a reliably good treatment if you have mild to moderate arthritis in the knee. If you have more advanced arthritis, it can be not quite as reliable. On the other hand, utilizing your own bone marrow-derived stem cells is certainly preferable if you have more advanced arthritis, and it certainly is helpful if you have mild to moderate arthritis. So partly it depends on degree of arthritis that can make a difference. That's how I generally look at it. Some of it is also, what else has this patient had done to them? Have they had surgery before? If they've had surgery, frequently I'll end up recommending bone marrow-derived stem cells because I know that joint has been surgically traumatized at some point, and so they may have more instability and they'd likely benefit from a stronger treatment. What medical issues make you a poor candidate? Great question. So a couple of things. I think if you have active metabolic issues, let's say your diabetes is poorly controlled, let's say your hypertension is poorly controlled, fatty liver, things of that nature. If you're on a lot of different medications, we try to get you to limit the medications that you're taking around the time of treatment because that can make a difference as well. I know if somebody has chronic inflammation, let's say they have rheumatoid arthritis or psoriatic arthritis, because I see that a lot, I recommend for patients that try to get the overall inflammation under control first, either optimizing whatever your medication regimen is or supplements or dietary changes. Maximize that first before approaching treatment. The key here is not so much, are there medical conditions that 100% make you a non-candidate? It's more, how do you optimize what you are currently? Ideally, every single candidate of ours would have only mild degree pathology and would be 20 years old and have no other medical issues. We don't see those people at all because the reality is that's not how humans present with their musculoskeletal issues. They present either with chronic arthritis or they've had an acute injury. And so that makes a big difference for sure. So to me, it's more about optimizing your medical issues. The one medical issue that I think does definitely require caution is if you've had, let's say if you have current cancer, I'd recommend having that properly treated and sort of taken care of and in remission before jumping to any of these kind of treatments. You can do prolotherapy, which is just injecting dextrose or sugar water, which can help with pain relief as well. Okay, so here's another question. Can you do one and then bone marrow later if the first treatment doesn't give you as much benefit? Absolutely. Utilizing a milder treatment, there's very little downside to that. In my experience, in cases where people have not had as good or robust a response to platelets, they can still get a good response to bone marrow. Absolutely, that's for sure. Yeah, you guys can keep coming with the questions, no problem. So, is this too good to be true? So Regenix has data that goes back to 2005 that we've been collecting. Philip Hernigue has data. He's an orthopedic surgeon in France. He has data that goes back to the early 90s. He's a real outlier. He's got data where he's actually compared his patients where he did knee replacement to his patients that got bone marrow derived stem cells in the other knee. And he's found equivalent sort of pain relief long-term. He's got patients where he's done shoulder repairs on one hand with just surgery, on the other hand with just bone marrow. And in some cases, even comparing that to surgery with bone marrow added on as well. And so there's data that shows the effectiveness that goes back, quite a ways. The bottom line is that the experience of this, while it's a rapidly developing field, it's not new. And even my own personal experience goes back to 2008. I think when physicians say, well, it's interesting, it's new, but there's no data behind it, they're not aware of the data. They're not looking for the data. They're not in the field, so that they're not going to see it. But there's certainly compelling data, especially when it comes to knees in terms of the effectiveness of treatment. Keep in mind, there's right and wrong ways to do this, as I mentioned before. And I think to do it correctly, you have to be incredibly diligent, incredibly detail-oriented, and really this has to be your focus. If it's not, you're not going to get the best outcome. And I think lastly, expectations, grounded in reality and evidence-based medicine. We can get good outcomes, but you have to also keep expectations in the sphere of reality. I've seen physicians who have told patients that they're able to rebuild cartilage in someone who's had chronic, badly damaged knee arthritis. That's not accurate. you can definitely improve pain and function. You can definitely improve chronic inflammation and improve quality of life dramatically and get them to do more physical activity, but you're not going to get their x-ray to look differently if it's been that badly damaged. I showed some pictures of how you can improve acute soft tissue injuries, absolutely. But again, keeping our expectations in the world of reality is important. How long do results last? Again, Regenix has data that goes 10 plus years. Philip Hernigue has data that goes over 20 years. I still tell people, if you have an acute injury, expect one treatment to be adequate. But if you have a chronic condition, you should expect repeat treatment at some time. That might be just repeating a platelet treatment at some point in a couple of years. It may be repeating a full-on bone marrow treatment. The evidence for repeat treatment is that when you've put somebody at a higher level, if they have a little bit of regression, if they get a repeat treatment, they're generally then bouncing up to an even higher level than that original treatment. So there is an additive benefit to these kind of treatments. Best way to maintain results after treatment, improve your biomechanics, take the appropriate joint healthy supplements, and again, repeating treatment if needed is additive to the initial treatment. Cost. So this is not routinely covered by insurance. Regenix, however, has contracted with a number of different self-insured corporations around the country where they have more control of their benefits. And in those cases, this is covered. In government-based insurance, Medicare still considers this to be experimental. TRICARE, which is the military insurance, does cover PRP at this time. So cost estimates, which you'll see around the United States, for PRP, it'll be roughly $1,500 as a starting price, and for stem cells, roughly $6,500 as a starting price. The keys to determine value that I would recommend are the physician and clinic regenerative medicine experts based on the things that I mentioned. Are you receiving a real stem cell treatment, which is coming from your own bone marrow, or are you receiving a bogus amniotic umbilical cord product that's being mislabeled as a stem cell treatment to you? And then lastly, these are in-office procedures. If you're getting a procedure done in the hospital or surgery center, understand that there may be additional facility fees that may also increase your costs, which are really not necessary because this can be done in the office. Okay, two other questions I'll kind of touch on right here. The one was, what supplements do I recommend? I think the three good supplements that have reasonable evidence of efficacy for orthopedic use are glucosamine chondroitin, omega-3, and curcumin or turmeric. I've got a couple of videos where I talk about that on my website and social channels as well. Another question about ozone. I don't personally use ozone. I do have colleagues that have used it. I don't think there's really a lot of evidence on its efficacy beyond what we can do with platelets and bone marrow. It's an interesting idea, but I don't incorporate it in my own practice. So in my own practice, here's our approach. Focus on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. That's our focus. That's all that we do. Evaluation includes, is there any degree of inflammation, instability, asymmetry from side to side, and neuromuscular issues? Really understanding the nuts and bolts of what's driving your issues. Try to correct originally with low-risk interventions, exercise and supplements. If it's not working, then we talk about regenerative medicine treatments. And my emphasis here is use the highest quality products from your own body, if possible. A plan that is specifically tailored for your own condition and needs. So changing up your platelet concentration, stem cell concentration as needed based on your particular issues, and delivering cells using the highest level of imaging guidance is an absolute must in my opinion. Okay, great question. What are the risks of these procedures? So risks of these procedures, no higher risk than what you see with any other type of needle insertion, meaning anytime you stick a needle into the body, there's a low but potential risk of infection, tissue damage, bleeding, nerve damage, and more pain. How do you minimize these? So we minimize these by, number one, utilizing standard medical protocols to reduce the risk of infections. Number two, utilizing high-level image guidance to make sure we're only injecting into the proper tissue that needs to be treated. Number three, utilizing treatments that have evidence of efficacy and low risk, meaning we're not injecting into non-orthopedic tissue that doesn't have good evidence of efficacy. And then, of course, picking the right candidates, meaning if you have reasons why you're an unsafe candidate, we'd want to flag that. We'd want to be very clear about candidacy for these kind of procedures as well. So overall, these are considered low-risk procedures based on all of those factors. So how do you get evaluated? So on your screen, you should see popping up, schedule your knee evaluation. If you're interested in being evaluated, you can click on that, click where it says click here, and that'll take you to an easy online scheduling where you can schedule yourself to be evaluated by me. Essentially, we do evaluations either via telehealth, or if you're local, we can also do it in person. Either one is fine. We do need to go over your history, any imaging that you've had done. If you don't have any imaging, we can even do a telehealth evaluation where we can at least get your history and figure out what we need to be targeting. If a in-office evaluation or diagnostic is required, that can be scheduled as well. But for the most part, we're able to do really the majority of this over telehealth these days. Great. Well, what other questions do you all have? Or I'll kind of open it up to chat if there's any other questions at this time. Okay, somebody asked, by the way, about are the slides to be emailed? They won't be emailed, but if you'd like to watch this, this will still be accessible for the next 72 hours. You'll be able to rewatch this or have a loved one or friend watch this as well. Well, great. If there's no other questions, I will go ahead and kind of shut this down. And if I can be of any additional assistance with either questions, evaluation, or treatment, I'm available at chicagoarthritis.com. And we are here to help out in any way needed. And I hope everyone remains safe and well. Have a good night, everyone.